I'm going to talk to you guys about stuff that surgeons and neurologists try to verify because sometimes the landmarks can leave you hanging. And I learned this both in my fellowship, but also when I came here to Seattle 20-some years ago. I had the luck of working also with Dr. Ogeman, who was a neurosurgeon who kind of just made a difference on this, studies of that, and so that advances this slide. So first thing we do a lot, and you're gonna see every time you see the neurophys team in the OR, one of the things we just do motor mapping. And then before doing motor mapping, we usually do what's called phase reversal testing that we try to help you guys from the landmarks that you have visually to try to establish which one of the sulci is really the pre and post motor sulci. Gyrus. And so just trying to find where the central sulcus is. And so this is what we do based on the SSCP. SSCP is a test where you, this is a pointer here. Oops. There's no pointer, right?
It doesn't work well on the screens.
Okay, all right. So you stimulate most of the times the median nerve. And as you stimulate the median nerve, you produce a phase reversal in the brain. And this is what you're doing. You have the exposed brain, and you have like a pattern just before the central sulcus, and a pattern that's different when you're in the motor sulcus, in the motor part. And as a surgeon, that's going to be your job, is to more or less align the strip with an angle that here in the United States we say 90 degrees. Germans like to use some funky angles of 60 or something. So if you read German and European manuals, they use different. Here in America, I think everybody uses that. They try to do 90 degrees. So the strip here and the sulcus here. But again, this is all about adjusting a little bit and seeing the pattern. This is the pattern that you're seeing. Motor should be downgoing, and the sensory part should be upgoing, okay? And we say phase reversal, but they are slightly off usually because you're stimulating the sensory part, and the motor part, you basically go, on the motor part, you basically go from the sensory to the bottom to the motor. So this is how you get it. So the sensory part, it will be a millisecond later. So this is what you do. Man, nowadays that we have all those screens on top on the OR, a lot of surgeons like us to display that over there. And you should learn, you should not be completely dependent on a neurophys team. You never know where you're going to be. You could be more experienced than the neurophys person. So again, I'm suspicious by nature. If it was you, I would just learn a little bit of the pattern. It's not that hard. So again, another one, motor here, sensory here, sensory going up, motor going down, and again, a little bit of a phase delay with the sensory being earlier than motor. And again, play around with this angle here, and then you hold it. Another caveat for you as you do that, man, is just if you're in an OR, make sure that if you're playing with the strip, make sure you don't land your strip right on top of the tumor because your waveforms may look funny. Okay, you may be right on the right position as far as anterior and posterior, but if you're on top of the tumor, your waveforms are going to look funny. Yeah, that's just the nature of the beast. You really want to avoid that. You want to get healthy motor and sensory cortex to have nice waveforms. And you can do that also in the foot area. And then you have to have your strip mesial. So that is what people call phase reversal. So now Once you find that, you're going to be a little bit better at finding motor areas and doing your motor testing. And depending on the surgeon, sometimes they'll do that more independently. Sometimes the neurophysiology team will do it. So those are a few things that you want to know. That one we talked about, brain tumors will push the anatomy a little bit. People with early strokes, especially strokes in the first year of life or earlier, will have the motor area in funny places, so that's the rule, not the exception. And people with cortical dysplasia will have motor areas in funny places too. Same thing for speech. And we'll see if we can get to the last thing. So, awake craniotomies is something that was championed by Penfield, even though a bunch of other people. Penfield went to Europe to learn that, and at that time, the Germans were really at the forefront. And with the First World War, there was a big setback. Obviously, they were more worried about surviving and whatnot. And the English and the German who were cooperating kind of lost contact because of the war, but Penfield went, spent some time in Germany, passed through France, went back to England. So this is how he brought this to America. He was American, by the way, not Canadian, as everybody thinks. He created the Montreal Neurological Institute, but he was born here in Washington State. And so you want to be careful. There's not a lot of cerebral edema. Make sure that the anesthesiologists know how to do patients that are going to be doing awake craniotomy. Uses something that gets out of the system quick, like propofol. And then if there's edema, he has to treat properly and hyperventilate and do the stuff that you guys all know to ask the surgeons to do, avoid edema and blah, blah, blah. And you've got to be very cautious with stuff that will really suppress too much of the activity, like midazolam and so forth. So I'm a pediatric neurologist. I always like to think about patients' age or mental age. So 12-ish, give or take, mental age is an age that you can start to do awake craniotomies. Below that age, people tend to freak out, and I've been to the OR to that people just diving under the drapes, trying to hold people that were a little too immature to have an awake craniotomy, and you find yourselves neurologists, anesthesiologists, circulating nurses, everybody trying to grab the patient. So you have to use your judgment a little bit on who can do an awake craniotomy. And then, and you can check people's motor map of the central sulcus with the patient under general anesthesia, except for throat and lower parts on your pharynx. Those are kind of hard. But you have to be mindful that your threshold may be changed a little bit if you're under general anesthesia. So we try not to do it. And then we always want to have seizure medications on hand, because the patients may seize. You want to have a neurologist looking at the EEG as you stimulate the patient, because they may have a seizure and you think you're getting a motor response and you're getting a seizure. And as a surgeon, you should be calling the shots in terms of having somebody bring you some cold ringers, lactate, and give that if the patient has a seizure during the middle of that. Or you can use also a stimulation to stop the seizures. And that is the parameter that we use to stop the seizures, 50 hertz, and small pulse of about 0.3 seconds to stop it. So this is the Penfield method. This is how you stimulate. Tend to use like about 50 to 60 hertz. As you can see here in America, people like to use 50 hertz, something that's a little bit off with the frequency of the wall alternating current. And the pulse duration, it varies between 200 to 1,000. The more immature you are, the more long pulse duration you use, because little people tend to have less myelination, does a higher resistivity, so you have to have a pulse that goes longer for you to deliver the same amount of electricity. And you stimulate brain biphasic pulse. That's a mantra, you know. And that's because you want to ionize and deionize the brain. Leaving the brain ionized is not a good thing. Okay, so when you stimulate, you have 2 points for the most part, like a bipolar. You can have a remote point, that's the monopolar. For the most part, you use a bipolar, and you create a field where the stimulation is effective. And even though this is an old slide by Nathan, I like to use it because it's one of the fields that really calculates the depth of the field and how deep you go with the pulse stimulation. And this is a map of where the stimulus goes and how effective it is. And the red line is the part that is effective. So yeah, about 1, maybe 2 centimeters deep, no more than that. So this is the bipolar stimulator. Again, we talked about ionization and the biphasic pulse. This has a name, and obviously I'm not doing advertising, especially now that the FDA is coming to approve more of those stimulators. That's the one that most people train here in the US. I didn't train on that. I trained on grass telefactor, which is the East Coast thingy. In the East Coast, people do use those old stimulators. They're a little bigger and clunkier, but they're coming up with the newer versions of that. This is the West Coast standard. So everywhere you're going to find some place that you can play with the pulse duration. You're going to have, the pulse duration is here. Remember, children use longer pulse duration. There's usually 3 settings, one in the middle, it's off. And up is the one that you are ready to do when you push your pedal. And you have a pulse rate. There's another parameter that you can use, man. It's just if you guys practice outside of the United States, you're going to see more and more that parameter of using continuous stimulation. Continuous stimulation is a different setting. You slap a strip on the person's head, and you go stimulating as you're operating. It's pretty cool, interesting, not FDA approved. Some centers here in America do that, even though it's not FDA approved. But this is the standard that we do, or the Penfield method, as it's called. So you got to be careful because most of the manuals tell you a voltage or amperage that is just related to one of the phases. What you're delivering is twice that. A trick that one of the surgeons taught me is that those stimulators can short. And then if they short, they will just go big, making a funny noise. And oftentimes you have to go there and just disconnect that. And remember, you stimulate always with the electrocorticography, so EEG simultaneous at the same time. And the neurologists will use a funny name called after discharge. What they mean is seizure. After discharge is a little seizure that you see with stimulation. I'm not sure who invented that name, but it's dumb but stuck. So everywhere you're going to hear that name. It's an after discharge. That's what they mean. It's a little seizure when you stimulate. And many times you're not going to have a clinical manifestation, so you really want to get somebody who knows how to read EEGs to tell you, oh yeah, there was a little seizure with my stimulation. This is a little seizure. So this is the stimulus, this is the artifact, and then after the stimulus you see a seizure. And seizure in EEG means there's something rhythmic, right? So get your guys' eyes used to it. People like Ryder, I've seen so many of that. He's probably just as good in pattern recognition. But you have to get your eyes used to it. And top panel is the first, bottom panel is the second, so it goes from top to bottom. And as you can see, it starts on this electrode and then spreads. Here it's just on this electrode, and here it's in this and this. And that's a normal pattern of seizures. Most of the times the surgeon will just say, hey, little zap to stop the seizure, if that's going too long and the cold saline didn't stop it. So motor mapping, there's several ways. This is the way that I like. You should, every time you see an after discharge, you lower a little bit the stimulus so that you try not to produce seizures anymore. There's always a risk of seizure. People have calculated 1%, 2%, something like that, depending on how high risk the patient is. And this is the Johns Hopkins method of stopping seizures by Ron Lasser created this. So that's somebody who was stimulating, produced the seizure, and bam, did a short stimulation. This is the stimulation number 1. Stimulation number 2, the seizure stopped. So this is what I was just saying to you that people are using in Germany. They are, and now many places in Europe where they learn with the Germans. This is the continuous stimulation. You put a strip on the patient's head on top of the motor area, and then you go stimulating as you go operating. Dr. Ribas was showing a surgery that he was going pretty near the motor area or the motor axons. And that's what people have used that for, when you want to know how far from the axons you are as you dig into the white matter. Because sometimes, and I have had that several times, I've been to the surgery and I looked at the surgeon looked at me and I say, yeah, that sounds like a great surgery, and then the patient comes off and he's a little weak. So we know that the surgeon did a good job. But still the patient comes off, it's a little weak. Many times it's transient, but sometimes it's kind of scary or definite. So that prevents you from getting too close from the motor tracks. And you can even do a proximity guesstimation to see how hard you have to stimulate to produce a motor response. And that's a neat thing that I like. This is the method, and you just use a little shorter pulse duration, and you use 250 hertz as opposed to 60 hertz that you use with the Penfield method. So that's stupid, but sometimes you will be amazed how many times people are paralyzed, and the anesthesiologist didn't tell the neurologist, didn't tell the surgeon. You go, dude, you're gonna do motor mapping. You knew that, but it happens, man. You have to be compulsive about that. It's just, I'm not sure if you've been in the military, like in the Navy, you have all those checklists. It starts with the dumbest thing, same thing. You'll be amazed. You have to know that the person is not paralyzed, and you have to ask. But it happens. So it's dumb, but it's there for a reason. So make sure the patient is not paralyzed, and use a verifiable thing, which is the train of 4. TOF, train of 4, you stimulate, and you should have, for every stimulus, you should have 4 consecutive responses. That's what train of 4 is. The EEG should not be in burst suppression. That's something that's more for the neurophysiology team. And it's easier when you don't use gas on a person. So this is the motor strip, and this is a paper based on surgical data showing that you can have motor responses not exactly on top of the motor strip, and it can vary a little bit. So just be careful. Motor is more reliable. But according to this paper, also from the Johns Hopkins group, Dr. Uematsu was there when this was done, but this was done by Ron Lasser, the same guy who did the motor, the zapping to stop the seizure. And so there is some variation on that. So motor, as a mantra, and as you learn in physiology and your functional residency and fellowship, you always learn that that's the most reliable thing. Yeah, it can leave you hanging sometimes. So sometimes the motor strip is not exactly what you think. And that's the bottom line of his paper, because we have not a lot of time. I'm just going to say that he was just trying to say that 1/3 of the patients was not smack on top of the anterior precentral sulcus. It was a little further away. And in kids, you may have to kind of zap them with a little bit more power because there's higher impedance, less myelination. Myelination, since the Vietnam era where they did more autopsies in young people and 19-year-olds, one good thing that happened during the war is that people did more autopsies in young people, unfortunately, but they found out that people kept myelinating as they go to the late teens. And some of those young soldiers that died, their brain was not completely myelinated. And so since we got that experience that came from the Armed Forces Institute of Pathology in the US, we know that, there's a reason for it. Now, kids always require a little bit more, especially if they're below age 12. So I'm gonna skip a little bit. This is the data from the Miami Children's Hospital showing the electrophysiology correlate to that, and that this is one of the leaders in that field. His name is Prasanna Jayakar, and if you get any paper from them, it's great. They're the people who have done surgeries on little people for the longest here in this country. And so this is a little bit more about the continuous stimulation. Those are the papers if you want to get some of that data. Put the strip, find the motor strip, leave that there, and go stimulating as you go, stimulating the patient as you go operating, trying to find a response. And then the mantra here will be, if it takes more than 2 milliamps of power for you to produce a motor response, usually you're safe. That means like you 1 to 2 centimeters away from the motor tracks, from the axon cables of the neurons from the motor strip. And that means that if you're a surgeon, you're navigating in the safe zone. And then I'm still waiting. I gave this talk a few years ago, and they're still not FDA approved, right? Right, they still don't have that there. Yeah, I haven't looked in the past few months on the FDA approval thing, but this is a German knee thing. This is a suction thing with the tip being electrically active, and they go stimulating and doing the surgery at the same time, which I think is pretty neat. And again, you can do passive ECOG, so you can do, you can put a grid of electrodes in the person's head, and then you can have them move the hands and see the change in signal. It's a little sophisticated, but you can do it. You just have to use a more mathematical algorithm to see the surge in greater than 60 to 100 hertz activity in the brain. Not many centers use, but there are a couple centers in the US that use that. SMA motor mapping, you can do that too. Something that not many people do, but he found that people, when they stimulate the SMA, they look like an SMA seizure. They stiffen, they have asymmetrical posturing, proximal limb posturing, same thing instead of twitching. Now, the next and probably most interesting part for you guys as surgeon is language mapping, because language has a huge variation. And so when you do language mapping, you have to be really attentive, and especially if you're somebody that you don't have a green light to operate as much as you can, you're just going to do a little debulking, or somebody that just has epilepsy and you want to improve their epilepsy, really will be very mindful of the patient's language areas. So those are patients that you have to save as the treating doc, the language area. And so that's the patients that you're going to be paying a lot of attention. And that's the bulk of what the data I'm showing you. Not, obviously, as a surgeon, you're going to make a call if somebody has a GBM, excuse me, and you're going to make a call, I want to take this out because I'm going to save the patient's life, and I don't care as much about the language. This is not what we're talking about. We're talking about when you really, really, really care about the patient's language area, because you're going to remove a seizure focus, and you want to improve his life, and so that's what we're talking about. So Basically, you present a lot of pictures to the patient and ask him to respond something. Oftentimes, you don't want to have the patient just saying what you present to them, and you go, so if you present this, he would never want to say glasses. You want to say this is da da da, so that you see if their language is fluent and if you see if they can name the object. So you want to see both. And you always want to get a baseline when you do that. And the positive response is both the speech arrest and not being able to name. And ideally, you want to try 3 times each site. And this is Dr. Ojimin's paper showing how much variation there is in language mapping. So we talked before, it's hard to trust some of the anatomical landmarks for some functionality depending where you are. Some things are very reliable, like the occipital cortex. Language area is among the not so reliable, even though we have an idea where the language is going to be. This is the spread here. This will be Wernicke's area. This will be the frequency of the finding Broca's area. The numbers inside of the circle is the percentage of you finding on that area. So this is 79% positive, 36% positive. But you can find still Broca's area all around. You can have Wernicke's area coming all the way anterior, all the way posterior, and occasionally up here in the front. So you really want to test. You operating dominant temporal lobe, you want to test. That's how you can be certain. The rest is you playing the odds, you're rolling the dice. And so we can do that in the OR, and you can do that when the person has a grid. The grid is cool, the patient is nice, relaxed, there for you to do and repeat 1,000 times. That's very nice. This guy here, those discs, which are the electrodes, are bigger than your stimulator in the OR. Current density is smaller. So if you get really, really pinpoint findings in the OR, with your stimulator that has a higher charge density, you trust what you see in the OR, but this should be your guideline because obviously in the OR, your time is limited. So we, as the clinical neurophys team, we should give you the map of the land, we should tell you where the city is. You should verify which block of the city the language area is. That's the reality of it. Okay, so, but we should be pretty precise. Most of the times I should give it to you a 1 to 2 centimeter region. But again, you having higher current density in the OR, you sometimes can overrule that if you're very careful. Those are abnormal responses, and obviously those of us who are foreigners, if we have testing, we are going to have effortful reading always, especially if you go laughter or those funny phonemes from the English language. But if the person is a native speaker, you should be able to figure out verb ending mistakes, again, foreigners excuse, changes in preposition. Brazilians always air the prepositions. So my wife is always making fun of me on that. And poor syntax is very dramatic in people who we know they're very articulate, obviously. And speech arrest. I'm going to skip sensory because we don't care as much. But people have mapped all those areas. People have mapped visual association areas, have mapped temporal lobe association, cortex. Obviously, while the Penfield was famous for going around and mapping areas that people see, little stories, had little movies, but that's not as important for us. So as a general rule, mapping language area is very important, but there are variables. Yeah, usually the nicest thing is for you the best data in language mapping is when people allow a 1 to 2 centimeter language-free area between the resection and where you find language. If you push the envelope, you can go as low as 1 centimeter. The best is 2, and that's the rules. You find yourself as a surgeon that sometimes you have to push the envelope, and then I'm not the guy who's going to say no, that's stupid, because you know the patient more and you know the clinical situation more. But that's the data that you should have in your brain. You should have 2 great, 1 okay, less than 1, you're asking for trouble. Be patient. You can't do that without being patient. A lot of surgeons cross their fingers, sit down in a chair, because obviously you guys all are a little hyperactive by nature. So a lot of surgeons I've seen, they sit down, cross their legs, and wait, close their eyes, because it takes time. It's not 2 minutes. If you do nice language mapping, it takes a little bit. Or sometimes they get more engaged. Sometimes the surgeons are doing, like Ryder does that, which is nice too, because they do, but they have a map and they have a plan with the neuropsychologists who are going to be showing the figures, and that's great. It's great to have a plan and know exactly how much it's going to take. But it is not super fast. And George Ogeman did a study with the IRB there at the UW, and he proved that adding 20 minutes adds zero, you know what I say? Adds 0 to the morbidity of the surgery. So you can rest assured somebody looked at that 20 minutes waiting in a brain surgery for a resection of epileptic focus has been validated, doesn't add the risk in nothing. So that's what that is. So 20 more minutes of sedation doesn't add anything. So just be calm, be chill, get used to the equipment, play around with that when you have a chance. You guys have any questions?